Hello and welcome everyone. This is Dr. Arpita Dubey, a pediatrician from Mumbai. And today we are going to learn something new in neonatology, something which is very simple and something which we encounter very frequently too. So I'm talking about hypoglycemia in newborns. Yes. So hypoglycemia in newborns. It is one of the most common metabolic problems seen in both the newborn nursery and neonatal intensive care unit. Most cases of neonatal hypoglycemia are transient and they respond readily to treatment. It is associated with an excellent prognosis. But the definition of hypoglycemia as well as its clinical significance and management, it still remains controversial. Why so? We are going to look ahead. So there is no universal definition for hypoglycemia. Why? Because the normal range of blood glucose is variable and it depends upon various factors like birth weight, gestational age, body stores, feeding status, availability of alternate energy sources like ketones, free fatty acids, and lactate, presence or absence of conditions like sepsis or HI, hypoxia encephalopathy. So therefore, an operational threshold has been defined by consensus. Now, what does this operational threshold mean? It is defined as plasma or whole blood glucose concentration at which clinicians should consider intervention. So accordingly, a blood glucose level of less than 40 mg per dl and plasma glucose level of less than 45 mg per dl has been taken as the operational threshold for intervention. According to WHO, hypoglycemia is defined as a blood glucose level of less than 45 mg per dl. That is 2.2 millimoles per liter. And according to the Hypoglycemia Guidelines 2015 released by the Pediatric Endocrine Society, neonates more than 48 hours of age should have higher thresholds. That is 60 mg per dl, specifically of plasma glucose, which is approximately 15% higher than the whole blood glucose. The thresholds for treating hypoglycemia depend on the presence of symptoms, the age of the newborn in hours, and the persistence of hypoglycemia. There is something called as transitional neonatal hypoglycemia. Now, what is this? As the name suggests, this is something which is seen in the transition from the transition during the birth. Okay, so it is something which represents normal physiological adaptation to postnatal life. It occurs in 10% of normal newborns. Fetus derives glucose from the maternal circulation through transplacental facilitated diffusion, which stops abruptly at birth. And then the newborn responds to this transition by glycogenolysis, gluconeogenesis, and by utilizing the exogenous nutrients available through feeding. As a result of this transition, the newborn blood glucose falls to a low point in the first 1 to 2 hours of life to as low as 30 mg per dl and then increases to more than 45 mg per dl, stabilizing at mean levels of 65 to 70 mg per dl by 3 to 4 hours of age. The incidence of hypoglycemia, it varies with the population and the definition used. Diagnosis of hypoglycemia varies with the age of the newborn in hours as blood glucose levels change markedly within the first hours of life. According to a recent prospective New Zealand study of infants at risk for hypoglycemia, which is defined as blood glucose level of less than 46.8 mg per dl for this particular study, demonstrated that 47% of LGA infants, 52% of SGA infants, and 48% of IDMs and 54% of late preterm infants were found to be hypoglycemic. So, more number of late preterm infants were found to be hypoglycemic. So, So what causes hypoglycemia in newborn? There could be broadly, there could be 3 to 4 reasons. So the first one is hyperinsulinemic hypoglycemia. What is hyperinsulinemic hypoglycemia? It causes persistent recurrent hypoglycemia in newborns, may be associated with an increased risk of brain injury. Due to decrease in serum glucose level, it causes suppression of fatty acid release and ketone body synthesis. Hence, it prevents the brain from utilizing secondary fuel sources. Some cases are transient and resolve over the course of several days. Others require more aggressive and prolonged treatment. Then it could be due to decreased production or decreased storage, decreased stores, increased utilization and decreased production. So hyperinsulinemic hypoglycemia. We see it in infants of diabetic mothers, that is IDM babies, in large for gestational age infants, that is LGA infants. It could be congenital, genetic, could be due to secondary to other conditions like birth asphyxia, in presence of syndromes like Beckett-Whitman syndrome, congenital disorders of glycosylation, and other metabolic conditions like erythroblastosis, maternal tocolytic therapy with beta agonist, malposition umbilical artery catheter, abrupt cessation of high glucose infusion, insulinomoles, and after exchange transfusion with blood containing high glucose concentration. Congenital or genetic causes of hyperinsulinemic hypoglycemia is seen in mutations of genes encoding the pancreatic beta cell ATP sensitive potassium channel like ABCC8 and KCNJ11. Okay. Where do we see decreased production or decreased stores? Commonly seen in case of premature infants, in presence of prematurity, in case of IUGR infants, that is in infants with intrauterine growth restriction or small for gestational age infants, SG infants. When there is delayed onset of feeding or when there is inadequate calorie intake. Increased utilization and or decreased production. It is seen in conditions of perinatal stress like in sepsis, shock, asphyxia, hypothermia, respiratory distress, and post-resuscitation. After exchange transfusion with heparinized blood with low glucose levels, reactive hypoglycemia after exchange with relatively hyperglycemic CKD blood, defects in carbohydrate metabolism like galactosemia, fructose intolerance, and glycogen storage diseases. And in case of endocrine deficiency, like adrenal insufficiency, hypothalamic deficiency, congenital hypopituitarism, glucagon deficiency, and epinephrine deficiency. In other amino acid metabolism defects, like in MSUD, that is maple syrup urine disease, propionic acidemia, methylmalonic acidemia, tyrosinemia, glutaric acidemia type 2, and likewise. In case of polycythemic infants, why? Because there is higher, because glucose utilization has increased due to increased cell mass, red cell mass. Maternal or infant therapy with beta blockers like labetalol or propranolol by prevention of sympathetic stimulation of glycogenolysis. Screening. So routine blood glucose screening is recommended in high-risk infants. High-risk infants are those infants with a birth weight of less than 2,000 grams, with a gestational age of less than 37 weeks, small for gestational age infants, or infant of diabetic mothers, large for gestational age infants, neonate with Rh hemolytic disease, neonates born to mothers receiving therapy with terbutaline, propranolol, labetalol, or OHAs, that is oral hypoglycemic agents. IUGR infants, infants with morphological features of growth restrictions like 3 or more loose folds of skin around buttocks and thighs, loss of subcutaneous fat, difference between hair and chest circumference of more than 3 centimeters. Okay. Then any sick neonate, those with perinatal asphyxia, polycythemia, sepsis, shock, etc. Family history of a genetic form of hypoglycemia, congenital syndromes like Beckett-Whitman syndrome, neonates with abnormal physical features like midline deformities, microcephalus, neonates on parenteral nutrition. Persistent hypoglycemia disorders. So newborns with genetic or syndromic disorders or congenital hyperinsulinism are susceptible to develop persistent hypoglycemia. Apart from routine blood glucose screening, such neonates should also be screened for the ability to maintain blood glucose level of more than 70 mg per dl if one feed is missed. The ability to tolerate fasting for 6 to 8 hours should be checked before discharge. Timing of glucose screening. Glucose concentration should be determined whenever symptoms consistent with hypoglycemia occur. For at-risk infants, screening is performed after the first feed. If the first feed is delayed, testing is recommended by 90 to 120 minutes of age. Pre-feeding glucose concentration should be measured every 3 to 6 hours for the first 24 to 48 hours of life. In asymptomatic at-risk infants, pre-feed glucose concentration is measured every 3 to 6 hours until at least 3 readings are more than 50 mg per dl in the first 48 hours of life. How to perform glucose testing? Glucose meters are very commonly used screening devices. They show large variations in values as compared to the laboratory methods, especially at low glucose concentrations. Hence, low glucose values with glucose meters should be confirmed by laboratory measurements, though treatment should be started immediately after withdrawal of the blood sample without waiting for the results. The variations between capillary and venous blood and plasma, immediate and stored samples is to be considered. Whole blood glucose value is about 15% less than that of plasma, and blood glucose levels can fall by up to 6 mg per dl per hour in samples that await analysis. Continuous glucose monitoring or CGM devices use a sensor that measures interstitial glucose concentration, which is reported to be reliable. They help in detection of hypoglycemia that may be missed on routine screening. CGMs require insertion of probe, which might increase the risk of infection. Also, it is unclear how to interpret the clinical significance of low interstitial blood glucose and whether treatment should be initiated. Lab diagnosis is hence the gold standard for measuring blood glucose. Symptoms. Now let's go to the clinical signs and symptoms. Symptoms can be neurogenic or neuroglycopenic. Neurogenic symptoms are due to sympathetic discharge triggered by hypoglycemia, including both adrenergic and cholinergic. Neuroglycopenic symptoms result from deficient supply of glucose to the brain. Many infants have no symptoms. Low blood glucose levels may be totally asymptomatic. This is very, very, very important. So what are the common clinical signs and symptoms that we see? So first of all, it could be very non-specific. Irritability, tremors, jitteriness, high-pitched cry, seizures, lethargy and limpness, hypotonia, cyanosis, intermittent ethnic spells or tachypnea, difficulty in feeding, exaggerated Moro's reflex, episodes of sweating, sudden pallor, hypothermia, and cardiac arrest have also been reported. Diagnosis. Asymptomatic hypoglycemia is diagnosed if VGL, that is blood glucose level, is less than 40 mg per dl to be confirmed by laboratory estimation, and the infant does not manifest any clinical features. Symptomatic hypoglycemia is diagnosed with a blood glucose level of less than 40 mg per dl with clinical symptoms. Additional evaluations are needed for persistent hypoglycemia, which could be due to hyperinsulinemia or defects in the carbohydrate and amino acid metabolism or due to endocrine deficiency. Diagnosing hyperinsulinemia requires measuring insulin level that is inappropriately high for a simultaneous serum glucose. The critical lab sample for diagnosing hyperinsulinemia includes glucose, cortisol, insulin, beta hydroxybutyrate, and free fatty acid estimation. Additional testing to evaluate for persistent hypoglycemia, growth hormone, adrenocorticotropic hormone, thyroxine and thyroid stimulating hormone, glucagon, plasma amino acids, urine ketones, urine reducing substances, urine amino acids, urine organic acids, and genetic testing for various mutations. How do we manage a case of asymptomatic hypoglycemia? So, when the blood glucose level is between 20 to 40 mg per dl, trial of oral feedings and repeat blood glucose level after 1 hour. Oral feeding could be in the form of expressed breast milk or formula. If repeat blood glucose level is more than 40 mg per dl, ensure 2 hourly feeds with 6 hourly monitoring of blood glucose level for 48 hours. The target blood glucose level should be between 50 to 120 mg per dl. If repeat blood sugar is less than 40 mg per dl, IV dextrose is started and further management is as per asymptomatic hypoglycemia. IV dextrose is started at 6 mg per kg per minute of glucose. Okay, Now, when the blood glucose level is less than 20 mg per dl, subsequent management is as per symptomatic hypoglycemia. Asymptomatic hypoglycemia. Direct breastfeeding is the best option when the blood glucose level is in between 20 to 40 mg per dl. Breast milk promotes ketogenesis. Express breast milk may be given if the infant is unable to suck. Where breast milk is not available, formula feeds can be tried. Recently, buccal 40% dextrose gel has been used for both prevention and treatment of asymptomatic hypoglycemia. A few randomized control trials in SG and AG infants that the sugar or sucrose fortified milk, 95 gram of sugar per 100 ml of milk, raises blood glucose level and prevents hypoglycemia, though this practice may compromise breastfeeding rates. Management of symptomatic hypoglycemia. All symptomatic infants should be treated with IV fluids. A bolus of 2 ml per kg of 10% dextrose should be given. A bolus should be followed by continuous glucose infusion at an initial rate of 6 to 8 mg per kg per minute. Blood glucose level should be checked after 30 minutes and then every 6 hours until blood glucose level is more than 50 mg per dl. If blood glucose level stays below 50 mg per dl in spite of bolus and glucose infusion rate should be increased in steps of 2 mg per kg per minute every 15 to 30 minutes until a maximum of 12 mg per kg per minute is reached. After 24 hours of blood glucose level therapy, once two or more consecutive blood glucose level are more than 50 mg per dl, the infusion can be tapered off at the rate of 2 mg per kg per minute every 6 hours with blood glucose level monitoring. Tapering has to be achieved with concomitant increase in oral feeds. Once a glucose infusion rate of 4 mg per kg per minute is achieved, oral intake is adequate and the blood glucose levels are consistently more than 50 mg per dl, the infusion can be stopped. The glucose infusion should not be stopped abruptly as it may cause severe rebound hypoglycemia. More than 12.5% dextrose infusion should not be used through a peripheral vein as it increases the risk of thrombophlebitis. It's very important for all the resident doctors working in the NICU. So, some useful formulas. How to calculate GIR, that is glucose infusion rate. Percentage of dextrose being infused into rate of infusion in ml per hour divided by body weight in kg into 6. Infusion rate is equal to, infusion rate in mg per kg per minute is equal to IV rate in ml per kg per day into percentage of dextrose used divided by 144. Infusion rate in mg per kg per minute is equal to fluid rate, that is ml per kg per day, into 0.007 into percentage of dextrose infused. So we have these three formulas. So what do you mean by recurrent or resistant hypoglycemia? When an infant fails to maintain normal blood glucose level despite a GIR of 12 mg per kg per minute, or when stabilization is not achieved by 7 days of therapy, is said to be recurrent or resistant hypoglycemia. Hyperinsulinism is the most common cause of persistent hypoglycemia. The criteria for diagnosing hyperinsulinism. Critical sample must be drawn at the time of hypoglycemia, that is when the blood glucose level is less than 40 mg per dl. Detectable insulin of more than 2 mi per liter, usual values of more than 5 to 10 MIU per liter in hyperinsulinism. Low free fatty acids, that is less than 1.5 millimoles per liter. Low ketones, that is plasma hydroxybutyrate, is less than 2 millimoles per liter. Inappropriate glycemic response to IV glucagon, 0.1 mg per kg at the time of hypoglycemia. Normally, blood glucose level rises by more than 30 mg per dl in 20 minutes. What are the important causes of resistant hypoglycemia? So hyperinsulinemic hypoglycemia or normoinsulinemic hypoglycemia. And potassium ATP channel defects, glutamate dehydrogenase activating mutation, glucokinase activating mutation, short chain 3-hydroxyacyl CoA dehydrogenase mutation, Becker-Pigman syndrome. These are the causes of hyperinsulinemic hypoglycemia. Then we go to normoinsulinemic hypoglycemia. Could be due to counter-regulatory hormone deficiency, like just seen in cortisol deficiency, central or adrenal hypopituitarism, or congenital adrenal growth hormone deficiency, inborn errors of metabolism like glycogen storage diseases 1, 3, and 6, disorders of gluconeogenesis, defects in fatty acid catabolism and ketogenesis, organic aciduria, galactosemia, hereditary fructose intolerance. What investigations to do in case of a resistant hypoglycemia? In blood and in urine. In blood, we need to do a serum insulin level, C-peptide, IGF, BP3, thyroid hormones, serum cortisol levels, growth hormone levels, serum ammonia, serum lactic levels, free fatty acids, blood, BOHB, galactose 1, phosphate uridyl transferase levels, tandem mass spectroscopy, genetic testing for mutations like SUR1 and KIR62. In urine, urine ketones, urine reduced substances, and urine GCMS is very important. What are the drugs to be used in a case of resistant hypoglycemia? First is hydrocortisone, followed by dioxide, octreotide, glucagon. So hydrocortisone in a dose of 5 mg per kg per day, twice a day, per oral or IV. And how does it act? It acts by reducing peripheral glucose utilization, increases gluconeogenesis, and increases glucagon effect. What are the side effects that we can see due to hydrocortisone? It is hyperglycemia and hypertension. Now, then diazoxide, which is contraindicated in SGA infants. That's very important. In a dose of 5 to 15 mg per kg per day orally. And how does it act? It is a potassium channel agonist. And what are the side effects that we could see? It may lead to fluid retention, hypertrichosis, and cardiac failure. Octreotide in a dose of 5 to 35 mic per kg per day, 3 times a day or 4 times a day subcutaneously. It acts as a somatostatin analog and inhibits insulin secretion. Cholelithiasis, transient growth impairment, tachyphylaxis are other side effects that we can see with octreotide. Glucagon is contraindicated in SG infants. Glucagon can be used in a dose of 0.2 mg per kg, can be given subcutaneously or IM, and it acts by increasing gluconeogenesis and glycogenolysis. Nausea, vomiting, skin rash, rebound, hypoglycemia, some side effects which we see with glucagon. What are the other management options for resistant hypoglycemia? Mammalian target of rapamycin inhibitors, mTOR, like sirolimus, everolimus, they act by inhibiting insulin production. Given orally in doses of 0.5 mg per meter square per day, divided in 1 to 2 doses, targeting a drug level of 5 to 15 mg per ml. Surgical treatment consisting of near total pancreatectomy can be undertaken in those who are resistant to medical treatment. Follow-up of hypoglycemic neonates. During follow-up, special attention is to be paid to neurodevelopmental outcome, overall IQ, reading ability, arithmetic proficiency, and motor performance. MRI at 4 to 6 weeks gives a good estimate of hypoglycemic injury. The infants need to be assessed at 1 month corrected age for vision, at 3, 6, 9, 12, and 18 months corrected age for growth, neurodevelopment, vision, and hearing loss. So finally, what is the outcome of neonatal hypoglycemia? The outcome of neonatal hypoglycemia is determined by many factors like duration, severity, rate of cerebral blood flow, cerebral utilization of glucose, and comorbidities. So what is the correlation between hypoglycemia and neurodevelopmental outcome? A systematic review involving 18 studies concluded that there is no good correlation between hypoglycemia and neurodevelopmental outcome. Patterns of cerebral injury and developmental outcomes were studied in 35 neonates with symptomatic hypoglycemia and was found that 94% had white matter abnormalities on follow-up at 18 months of age and 65% had impairment in development. Children with hypoglycemia and their later development study prospectively evaluated the long-term effects of neonatal hypoglycemia in 477 at risk late, preterm, and term neonates, and found that hypoglycemia was not associated with increased risk of combined neurosensory impairment at 4.5 years, but was associated with a dose-dependent increased risk of poor executive function and visual motor function. Severe, recurrent, and undetected episodes of hypoglycemia increase this risk. What are the differential diagnoses? If symptoms persist even when the blood glucose level is in the normal range, other etiologies should be considered, like sepsis, central nervous system disease, toxic exposure, metabolic abnormalities like hypocalcemia, hyponatremia, hypernatremia, hypermagnesemia, pyridoxine deficiency, adrenal insufficiency, failures, heart, liver, and kidney. So here is a flow chart showing how do we manage a case of hypoglycemia. Hypoglycemia is defined as a blood glucose of less than 40 mg per dl, which could be asymptomatic or symptomatic. In case of asymptomatic patients, we can divide into further two categories: those with a blood glucose level between 20 to 40 mg per dl, and other half with a blood glucose level of less than 20 mg per dl. So those whose blood glucose level is between 20 to 40 mg per dl and they are asymptomatic, we give a trial of oral feeds and monitor the blood sugar after 1 hour. If it is more than 40 mg per dl, we give frequent feeds to the baby and monitor blood glucose accordingly. Stop after 48 hours. The monitoring is stopped after 48 hours, and before discharge, we ensure that there is no feeding difficulty. Suppose after giving the first trial of oral feeds, and we measure the blood glucose after 1 hour and find that it is still less than 40 mg per dl. So now what to do? Then we treat the babies as a case of symptomatic hypoglycemia. Now, how do we manage a patient of symptomatic hypoglycemia? That is when the blood glucose level is less than 40 mg per dl and the infant shows some symptoms which include seizures as well. So we give a bolus of 2 ml per kg, 10% glucose. Even in case of infants with asymptomatic hypoglycemia and blood glucose level of less than 20 mg per dl, we give them IV glucose infusion at the rate of 6 mg per kg per minute, monitor hourly till they are euglycemic, and then 6 hourly. Okay. Even when after giving a trial of oral feeds, in case of asymptomatic hypoglycemic newborns with a blood glucose level of less than 40 mg per dl, we directly start a glucose infusion at the rate of 6 mg per kg per minute, and then monitor every hour till euglycemic, and then every 6 hourly. So during that monitoring, we find that the blood glucose is more than 50 mg per dl. What to do now? And it is stable, that is blood glucose, it remains stable and above 50 mg per dl for 24 hours on IV fluids. Two values of blood glucose are more than 50 mg per dl. Then we slowly wean off, we slowly taper the glucose infusion at 2 mg per kg per minute every 6 hourly, and simultaneously we increase the oral feeds. Then monitor it every 6 hourly. Stop IV fluids when the rate is 4 mg per kg per minute and the infant is stable. Stop monitoring when two values are more than 50 on full oral feeds. Okay. Okay. Now you have started the glucose infusion at 6 mg per kg per minute. Suppose you find a baby with symptomatic hypoglycemia. After giving a bolus of 2 ml per kg of 10% glucose, you start the baby on glucose infusion at the rate of 6 mg per kg per minute. Also with those infants who are asymptomatic and they're hypoglycemic, their blood glucose level is less than 20 mg per dl, you start them on IV glucose infusion at the rate of 6 mg per kg per minute. Okay, and you start monitoring every hourly till they are euglycemic, and then you do it every 6 hourly. Okay, after during this time, you find that the blood glucose is still less than 50 mg per dl. Now what to do? So you slowly increase the glucose infusion at the rate of 2 mg per kg per minute till the child is euglycemic. You increase the glucose infusion till a rate of 12 mg per kg per minute is reached. Okay, still they are not able to maintain glucose level more than 50 mg per dl. Now what to do? refer to a specialist center for further investigations, including and consider hydrocortisone, dioxide, glucagon, and octreotide. Consider this as a case of resistant hypoglycemia. So thank you so much for listening. Thank you. Thanks a lot for patient listening.